Moving right along, next is the Kentucky Medical Association, Dr. Manslamdoost. Do I have that right? Doost. I'm sorry. Doctor, come forward. We all know Corey Meadows, our friend Corey Meadows. Come forward to the table. Welcome. Sorry you had to wait so long. Long agenda. But introduce yourself for the record and proceed with your testimony.
Well, good morning, and my name, as the chairman indicated, is Corey Meadows, and I am Director of Advocacy and Legal Affairs for the Kentucky Medical Association. And Mr. Chairman and members of the committee, as well as licensed and occupation staff, who've been fantastic to work with, we thank you on behalf of Kentucky Medical Association for allowing us to address you regarding this very important issue. I intend to reserve a majority of my comments for the doctor. I'm a lawyer by trade. That's the last person you probably need to hear from on this issue, so we're going to reserve our comments largely for Dr. Maslamdoost. But before turning it over to him, I thought it would be of help to you and some value to you to understand what the current KMA policy is, the explicit policy. And if you'll oblige me, I'll run through that very quickly before I turn that over to the doctor. KMA supports further clinical research, as approved by the FDA, to determine whether cannabis can truly be effective in the treatment of medical conditions. Marijuana's status as Schedule I controlled substance should be reviewed and possibly changed for the limited purpose of research and the development of cannabis-based medications. You heard from Dr. Barnes this morning. When you do this the right way, there can be very promising results for particular conditions, and that's the type of research that the KMA is advocating for in its statement. If scientific evidence confirms that cannabis-derived substances possess medical benefits, certainly alternate delivery methods should be explored in order to avoid the inherent dangers of smoke inhalation and the uncontrolled variables affecting potency and dosage. And until such goals are achieved, and until such time as marijuana is approved for use by the FDA, KMA cannot support legislation intended to involve physicians in the area of medicinal marijuana outside of scientific clinical trials. It is also the further policy of KMA because attitudes are changing, and the dialogue has certainly shifted in the last several years, to be an organization that facilitates evidence-based dialogues on the issues of cannabis in medicine by hosting forums, panel discussions, participating in conversations such as this, and other educational programs for physicians, policymakers such as you, and other interested stakeholders. This policy largely reflects the policies of other statewide medical organizations such as the Kentucky Academy for Family Physicians, who I think you've received a statement from. It also reflects the policies of the American Medical Association and other national medical groups. So with this policy in mind, and certainly with your permission, Mr. Chairman, I'll stop here and allow Dr. Maslamdoost to formally introduce himself for the record and take the remainder of our time. But I will stick around for questions.
Welcome, Doctor. Introduce yourself and proceed with your testimony.
Thank you. Thank you for having me. My name is Danesh Maslamdoost. I'm a born and raised Kentuckian and the proud son of two immigrant physicians who were pioneers in pain management in this state. Following in their footsteps, I pursued training in medicine, anesthesiology, and eventually pain management. As many other states swing toward liberalizing marijuana use, I'd like to explain why I, as a scientist and a physician, advocate for restraint. As an anesthesia resident at Johns Hopkins, one day a mentor suggested using a medication derived from the cocoa leaf. At that point, I only knew of cocaine, a dangerous street drug that came from that product. So I looked it up the night before and was able to find well-established studies on dose, potential complications, and indications. That day, I had a single refined molecule that had been heavily studied to use in the operating room. Now, don't get me wrong, I'm not advocating for cocaine, but like cannabis, cocaine comes from the cocoa leaf, and it's not one molecule. Marijuana is the composition of over 500 molecules, 60 of which appear to be biologically active, 4 of which we've really somewhat researched. In raw form, it's impossible to obtain consistent levels of active ingredients because they compete for the same receptors, which lowers the efficacy of the needed drugs. Even in the best case scenario, cannabis oils like Charlotte's Web cannot concentrate CBD over THC enough to avoid the psychoactive properties. CBD, like Dr. Barnes mentioned, does not equate with marijuana. Small variations make huge differences. For example, adding a methyl group to a known therapeutic molecule can dramatically change its effects. Amphetamines, for instance, are used in allergic reactions and become life-saving drugs. If you add a meth to it, it becomes methamphetamine, which we all know is a devastatingly addictive drug. You can't pick and choose which ones to absorb when you're dealing with a complex of molecules. Furthermore, as it stands, there's little oversight of additives, microbes, pesticides, fertilizers, and other chemicals, which may change its effects from marijuana manufacturers. There's no drug in medicine that we prescribe without knowing exactly what's in it, how much to give, how often, and what the therapeutic levels are. There are pharmaceutically derived marijuana products, like dronabinol, and still others in phase 3 trial, like what Dr. Barnes mentioned. The first time I used a marijuana derivative was when I was a fellow at MD Anderson. Every physician has a handful of patients they remember from training. I remember a young 16-year-old female. She was raised by her financially strapped single mother, and she was a straight-A student, a track star, and wanted to become a physician, much like myself, she would tell me. I met her when she walked into MD Anderson, laughing and smiling, and I was at her bedside several months later when she was dying. Toward the end of her care, she really writhed in pain. Her mother was terrified and desperate, and despite an 8th grade education, she struggled with medical textbooks to help us find not a cure for her daughter, but just something to ease her daughter's misery. While we didn't have a lot of success with other patients, we decided to try dronabinol, the cannabinoid derivative. In spite of her mother's high hopes, it didn't work any more than the conventional therapies that we had tried did. And moreover, she became more sedated and lethargic. When she passed, I was haunted by many questions. Was it too much? Was it the reason she became unresponsive when previously she was able to share stories with her mother about track, school, boys? I don't disagree with the spirit of Senator Garvey's proposition, but in practicality, it's problematic. Senator Clark mentioned there are 420 different strains used in medical marijuana. Well, which one do we choose? And how much to avoid its side effects? We can sensationalize the failures of conventional medicine as a rationale for legalization. Even though these cases evoke heart-wrenching sympathy, they are not representative of the average medical marijuana recipient. After legalization in California, the average recipient was a 32-year-old white male, of whom 50% had a lifetime prevalence of cocaine and 75% had lifetime prevalence of methamphetamine. In Arizona, vague diagnoses such as chronic pain are cited 87% of the time as the rationale for use. Chronic pain is not one single entity, just as how cancer is not one single entity with one single treatment. That's why we have experts and research to figure out the best and safest treatments for the many diseases that we see. The arguments that legalization will reduce the burden on the justice system and save billions of dollars is also superficial. According to the White House, only 2% of state prisoners are incarcerated with marijuana-only charges. The cited statistics on the number of convicts with marijuana are political manipulations. If someone is charged for rape or murder and they were caught under the influence of marijuana, that is added to the statistic of marijuana incarcerations. After legalization in Colorado, there were increases in DUIs related to marijuana, motor vehicle accidents related to its use, and higher fatalities when higher doses of marijuana were found. In the Netherlands, legalization did not reduce cartels. Actually, they flourished because they were circumventing taxation and dose restrictions, and it was harder for them to be caught. The biggest impact of normalizing legitimizing marijuana is in the adolescent population. My colleagues in pediatrics hear from a lot of teenagers that marijuana must be safe if it's used for medicinal purposes. This impression is especially dangerous for adolescent brains. While Dr. Barnes mentioned that CBD does not appear to affect the developing brains, there are components of raw marijuana which do. Contrary to what your teens tell you, their brains are not fully developed and won't be until their 20s. Like many psychoactive substances, early and regular users of marijuana show signs of developmental changes in areas of brain that help with motivation and coping skills. This means that an adolescent user is biologically less capable of self-soothing and more prone to a lifetime of seeking chemical coping mechanisms. This, by definition, is a gateway drug. We know that marijuana irreversibly drops IQ by 8 points at least. Marijuana users and even children of users show lower life motivation and achievement rates. The risk of provoking schizophrenia and psychotic breaks is 6-fold higher in users, and it's still unclear who's genetically vulnerable and who's immune. While it may give the illusion of a calming effect to bipolar and PTSD patients, when the drug effects fade, which happens unpredictably, there is a rebound volatility. 50% of daily users show signs of physical dependence, and because of its solubility in fat, their withdrawal symptoms can last for months. In fact, marijuana addiction rates can exceed even those for alcoholism. In the professional workforce, marijuana is associated with higher rates of absenteeism, work injuries, and disability. Kentucky ranks among the top 5 for disability. Can we really afford more people? The argument for economic gains through taxation and jobs are easily offset by the intangible impacts on productivity, accidents, disability, and that doesn't even count for the health costs. I understand the desperation to treat loved ones regardless of the cost. I felt that when I was taking care of my young patient at MD Anderson. But in the moment, it's impossible to maintain a cool, pragmatic perspective and weigh out the damaging effects from the possible benefits. It's a heavy burden on families and caretakers to make the decisions out of desperation without the benefit of foresight or scientific backing. There are well-established mechanisms for studying harms and benefits of a drug prior to its widespread distribution, and yet we still sometimes get it wrong. Think of the drugs that cause babies to be born with birth defects, the ones that inadvertently cause heart attacks, or the ones that we were told are harmless and turn out to be carcinogens. Now magnify that by 60 times for all the different chemically active compounds in marijuana. Using vulnerable and desperate populations to push through a complex chemical compound that at best has shaky body of evidence is reckless. Like the millions of other drugs being studied for the millions of conditions without good treatments, cannabinoids deserve the opportunity for more study, but this would require federal downregulating of the DEA scheduling. After all, marijuana is in the same category as heroin. In its native form, marijuana shows insufficient therapeutic benefit over existing therapies that can justify its known harms. Thank you.
Thank you, Doctor, and thank you for staying within your time limit. We always appreciate that. We do have several questions. The chairman recognizes Senator McDaniel.
Thank you, Mr. Chairman. I appreciate your indulgence. And Doctor, thank you for your testimony. I just want to establish something really quick because you brought up a lot of good points and obviously a tremendous amount of disagreement with some of the things that you had said from the expressions I saw behind you. At Case Western, what was your degree in?
Case Western, I studied the economics of healthcare and business management.
And you have a doctorate from Johns Hopkins University?
Yes, sir.
And you were an intern at the University of Cincinnati College of Medicine?
Yes, sir.
You were a resident at Johns Hopkins University and a fellow at the University of Texas Health Science Center, correct?
Yes, sir.
Thank you, Doctor.
Chair recognizes Representative Owens.
Yes, I have a question. I was wondering if we could get a copy of his comments distributed.
Excellent idea, and I will request that you provide those to the committee. I, too, would love a copy of those comments. They were very, very helpful to me. Chair recognizes Representative Montel.
Thank you, Mr. Chairman, and Doctor, thank you for your testimony. Just trying to follow some of the things that you said versus some of the things that I heard, particularly from the doctor that preceded you earlier in the day. And I seem to, at least from my perspective, my understanding was that there was a lot of positive research coming forward with the CBD form of the drug or of marijuana. Yet I don't hear that from your testimony. Is there conflicting views within the medical community?
No,
maybe you can clarify that.
Yeah, it's complicated. Let me explain it with an analogy. Think of CBD as a carrot, and think of marijuana as soup. The carrot is one ingredient in the soup that is marijuana, and CBD does have therapeutic efficacy, But when you're mixing it in with all the other chemicals that are in marijuana, the efficacy drops because you've got competing products that are trying to vie for the same receptors. And you've got compounds within marijuana that are dangerous and psychoactive and have harms to it. So you can't talk about medical marijuana as one product. You have to talk about it as 60-some products. And without research, we can't differentiate what the good stuff is from the bad stuff.
So then you would say the testimony given on CBD would be a form of that you would be comfortable with.
Absolutely. And there are products in the pipeline, like you mentioned. Sativex is one that has CBD as well as THC. And there are other compounds that are just CBD alone. As Dr. Barnes mentioned, there are products that we anticipate coming to market within a year or two. And I know that's a travesty for the people waiting for it now. But we also have to consider the harms that can come from just wild exposure.
Very good. Thank you.
Doctor, again, I want to thank you for taking your time with your credentials to come here and share your thoughts with the committee, and we would appreciate getting your thoughts reduced to writing.
Absolutely.
Thank you, Corey, for being here also. Always great to see you.
Thank you, Mr.
Thank
Chairman.
you.
You as well.